numbers of people who are in attendance. My name is Andrew Cooper. I'm Associate Director for Patient Safety at the Innovation Agency and the Patient Safety Lead for the North West Coast Patient Safety Collaborative. As I mentioned, this meeting has been arranged at short notice, and the reason for that is, as I'm sure most of you, the majority of you are aware, the significant increase in COVID cases that we are seeing within our region. So we wanted to really pull together some this webinar and this meeting around some the support that we can offer to support the rollout of COVID virtual wards within our region. I just had a couple of items of housekeeping. I think we've already mentioned that that there is an Eventbrite link which has been I've just pasted into the chat. The purpose for this is just to enable you to register your details. It will look a bit strange because you'll be registering for an event that's already taking place, but it's so we can keep in contact with you and send out information on an ongoing basis to you as the COVID virtual wards develop. And the other thing to mention is that we will be recording this session, and we will be able to share the link to the session for any colleagues who were unable to attend. So once again, thanks for your attention and your attendance this evening. And I'm going to hand back to Katie. So Katie is our workstream lead for the Deterioration workstream and is taking the lead locally on this piece of work. So Katie will chair the meeting. Thanks, Katie. Just on mute, Katie.
Sorry, can I just check that you can see the screen there with the agenda? Has that come up, Andrew?
Yes, it has. Yeah, thank you.
That's brilliant. So thanks very much for joining us this evening. As Andrew has mentioned, we've got over 150 people on the call. I think 160 we've just hit, which is phenomenal. So thank you at such short notice. Absolutely delighted today that we've been joined by Inada-Kim, who is the NHS England and Improvement Clinical Lead for Deterioration, National Clinical Lead. We also have Dr. Bushra Alam, an EAU consultant from Salford Royal, to share the experience of how they've deployed COVID virtual wards over Greater Manchester as a system approach at quite a rapid speed. And then we've also got Professor Naomi Fulop on with us as well to share some of the evaluation of the virtual models that have been going on in a few sites around the country. So we have got a lot to cram in, so I'm going to hand over to Matt now, and if we can utilise the chat box for any questions. I think we'll have questions at the end of our three speakers. It's probably the easiest way to do this, and we'll answer as many as we can in the chat at the same time. So I'd love to introduce Matt now. Thank you.
Thank you very much, Katie. Can you all see the slides? Are they coming up?
Yes, they are coming up.
Brilliant. Yes, you can see the slides.
So really nice to meet you all. My name's Matt. I'm an acute physician, was a GP when I was a good clinician, and essentially I've like all of you been wrestling through COVID from a clinical perspective. I think through the beginnings of first peak. Why are we here? So I guess through my practice, what I noticed was patients tipping up quite late in the course of their illness, often blue, and unfortunately often unsalvageable. Saturations in the low 60s and 70s was not unusual, and a shift where we had to do 3 rapid sequence induction ventilations or intubations in the ED were not uncommon, often within an hour. It was that bad. And what this is all about is translating late to early, because early we can do something about. Early we can potentially save lives. And with the advent of dexamethasone, remdesivir, anticoagulation, proning, early oxygen treatment, the potential is there to be so much better than we were with first peak. So silent hypoxia is what this is about. The political commentators like Peston even noted that this virus was causing oxygen levels to dip to pretty low levels without any accompanying severe difficulty with breathing, making this a really hard shifting target to hit. And there were sorry tales all around the country of people who tipped up and eventually died without symptoms of breathlessness, but feeling terrible in other ways. And that was certainly the article that Peston wrote recently for The Spectator. This is not about the hospital. So although there are things we can do in a hospital, this is about the community. This is about what we can do to empower patients to spot early deterioration using the tech that's available, including pulse oximetry and education and training, with an idea of how to access the NHS and when to access them, and what to say on the phone, to have clarity of our triage systems, to ensure that we do better than we did with first peak with a case fatality rate of 14.4%, and try and drop down to the levels of more developed countries around the world, and don't go down the trap of seeing what happened with Spanish flu all those years ago. So the virtual ward model involves a pattern like this, where you tip up with your symptoms of coronavirus, potentially in the community, in the hospital, and potentially the ambulance. You get your clinical assessment of one form or another, be it remote or face-to-face. You have your test for COVID. And what is variable at the moment is the use of oxygen saturations. And I'll tell you why they're so important in a sec, in terms of the evidence. And the question of whether we can unify that pathway to think about how we manage patients both with COVID and without. Because let's face it, a lot of people will tip up and require assessment who might have respiratory illness or an infective illness, and we won't be sure what's wrong with them. They'll need to be seen in a hot environment, and they'll need a triage system to ensure we ensure their safety and the safety of others around them. So the virtual ward model describes a package of monitoring that is used to monitor patients in that environment, to look for future deterioration and ensure their safety, and ensure that they are brought to the attention of the medical fraternity and nursing fraternity sooner in their illness. So when you do the risk assessment, it's divvying up patients into high risk, so those who are older, BAME, obese, comorbidities, who get that more active follow-up, and then low risk patients who have a slightly reduced intensity follow-up, with then the aim of picking up the early deterioration and then managing them appropriately. And, I hope we get a chance to listen to Emma Easton and in a bit, and talking about what volunteers might have to offer in terms of how we do that initial early triage with oxygen saturations, because that is really important going forward. So the strategy naturally was born around aligning that clinical model, knowing what we were doing in community, ambulance and hospitals, being on the same page, no different to what we need to do in every single condition, in my humble opinion. Developing the remote assessment model, the virtual ward model, safety netting, making sure our digital tech aligns with that model, that they're interoperable, that bridge all settings where possible, and that these are evaluated at scale. And we're honoured that Naomi Fulop has come today to tell us what the early findings are, and that's really important. And then the scale and spread, and Bushra will tell you about the amazing things she and the team in Manchester have done, things that we need to learn about, both in my patch and potentially wider around the country. The pathways themselves are pretty simple and follow the same lines: the emergency department, care home pathway, the primary care pathway, all using the same lines in the sand of oxygen saturations and red flags. And if you're not admitted to hospital, essentially, you fall into this virtual ward follow-up category. Why is oxygen so important? So this is a 2,500 patient study looking at patients that were conveyed with suspected COVID from the pre-hospital environment to the hospital in my patch, 2,500 patients during first peak. And we wanted to hit those patients with suspected COVID. And we wanted to look at the oxygen saturations at their first presentation in the community, because the hypothesis was one oxygen saturation at the beginning point of the journey could predict mortality. And, what we found essentially is that it probably does. This is unpublished and we need to get it written up soon. But essentially 30-day mortality, SATs below 93%, is a 28% mortality rate. Staggeringly high, isn't it? And then the 93 to 94% is 13%. So still pretty high. And when we did the same study and looked at emergency departments, and Tara Sood and her team did a terrific job in the Royal Free, it's pretty much the same levels of mortality rate. So your pre-hospital oxygen saturations maps to your hospital saturations and maps to your hospital outcome. And just like in News 2, we know that your community News 2 and your community oxygen levels predict your eventual outcome. And it's time we acted on that. Happily, our oxygen saturations lines in the sand are pretty accurate in terms of what the severe, moderate, and mild levels should be and how we should activate the pathway based on that. Because if your mortality is 14%, should you really be kept in the community with SATs of 93 to 94, or do you in fact need a hospital assessment? And this is where the philosophical change has happened between first peak and second peak, because now we know that dexamethasone, remdesivir, oxygen treatment, proning, anticoagulation saves lives with minimal hypoxia. Perhaps it's time we changed our practice and thought again about the protect the NHS mantra that we've used up till now. The other wisdom we've gleaned is that actually symptoms can predict outcomes. So if you looked at all the possible symptoms that can come with COVID and then rank them by predictiveness of death or intensive care, we know that breathlessness, myalgia, chills, and severe fatigue are the top 4. And that actually anosmia or loss of taste don't predict who's going to die or end up in intensive care. They do predict who might have COVID, however. So they're more green type symptoms, and it's using that evidence to develop our pathways going forward, whilst also not forgetting that you don't always have to have COVID. The equally bad stuff can happen around that, and our pathway has to hit the mark for those patients that don't have COVID. It also has to hit the mark with personalised care. You can't admit and intubate and ventilate everyone, and we need to think about the needs of our population, both because of frailty, extremes of age, or personal wishes. You don't have to admit everything and everyone, but you do need to develop a palliative pathway if you're not doing so, and potentially oxygen treatment and potentially dexamethasone where appropriate. So the what here is around how you manage patients who are high risk versus low risk. And what we've been doing is tracking them with phone calls or app interventions at days 2, 5, 7, 10, and 12 of the onset of symptoms to see whether there's a deterioration. Using diaries for patients to record their oxygen saturation meters, for which we bought 210,000 for the country, and then monitoring within either a primary care framework or a secondary care framework or a care home framework. And then following patients up with the 3 times a day monitoring to actually see how they do. So the oximeters are bought, they're in a warehouse, you need to request them. The emails we'll share at the end. And basically, we were, from a hospital perspective, for the average 600,000 population, we were looking at about 300 oximeters. For general practice, we have other equations to calculate it. For care homes, it's about 1 oximeter for every 25 residents. And with safety netting guidance is in evolution and about to be complete this week, we hope. The diary is in written paper form at the moment, but it's been translated into apps and also instructs people how to use an oximeter, what the red flags are, and how to record and use the diary. There are animations and videos instructing people about coronavirus in different languages that have been produced by GPs and community health professionals in the South, and they really do drum the messages home. And the apps have all been sort of developed to think about how they interact with the COVID virtual ward strategy to try and make it easy for patients and also clinicians. And they do save time when they're done right. But obviously our dream in the end is going to be interoperable digital systems, something we're not quite at that stage yet, but it's something we need to bear in mind for the future. So the apps themselves, so the animation talks you through what COVID's about, how to record your oxygen saturations, and when to call 999, 111, and how to record your oxygen saturations, and with the translations therein. And we'll share the links for that. An equally important part of this is the fact that some services only run Monday to Friday, 9 to 5. And we need to make sure we link up what happens in the community with the hospital, with admissions, with a safety netting service that underpins it all. So this is our opportunity. How do we ensure the system is safe for not only all time periods, but all types of patient, those with learning disabilities, mental health, those who don't speak English, those who are poor. This cannot be an unequal system of care for all. We need to address that. And we don't have this digital system to link us together. So the question is, what are we going to put in as our safety netting service if we set up these various aspects of amazing care within certain time periods? And that's a challenge to us in every region going forward. So a question leveled at us was, if you give the population oximeters, does it cause an increase in 999, 111 or CAT2 ambulance activity? And so far the answer is no. So we began a pilot in South Central ambulances in June of giving oximeters out to those at risk of COVID and those who are symptomatic of COVID in a 600,000 population in North Hampshire. And what we found was there was no increase in CAT2 calls or 111 calls that we could record. So we changed our pathways down south to essentially encompass oxygen saturations at the call handler level. And we're going to take that to NASMED because I think it probably needs to come in everywhere as being a way for keeping the patient safe. And actually, you know, in some ways thinking, you know, if you've got oxygen saturation recording means at home, you should be able to transmit that to the NHS and the NHS should act on them. So our safety netting is in discussion at the moment. So this isn't the final version by any means. And we're just discussing where we put that line in the sand for safety netting. Because as soon as you get 93% or below, you're looking at 26% mortality at 30 days. And if you go 94% or above, it's only 6.8%. So it feels like a natural split in perhaps where we should put that safety netting guidance. And if you think about the treatments, dexamethasone reduces mortality by between 20 and 35% in patients with COVID who require oxygen treatment. It's a black and white answer. So a scale and spread model from my particular patch has been starting off with 2 community hubs looking after 200,000 population each, 1 trust ESTEC looking after 600,000 and 100 care homes, all within the same pathways. And the idea is to try and scale and spread that across the entire 2 million population in due course. So far, we've seen about 2,000 patients. We've only got really excellent data on the 130 of those patients so far. And so far, there have been 0 deaths. So we're really happy with it, and we're going to scale it up at pace as a result, and probably do the same across the whole of the south of England. But that's not where the cases are. Unfortunately, you know where the cases are. And the question is whether this model is something you want to consider. We have a national learning network, which you're very welcome to join. And it was built to help regions, essentially. We've had 4 meetings so far. We have an incredibly active, enthusiastic group of people sharing what they've done. And we're all over social media, essentially trying to share best practice. There's no ownership here. It's all about helping each other to help patients, essentially. And we run an e-forum, which we have 550 members on, again, hugely active, wonderfully moderated, and really speaks to the frontline central engagement that needs to happen going forward, because we don't have all the answers. It's about figuring out the answers together to get to the right solutions for each region and locality. And the what next is really whether we've got the will now to do this in your region, in your great city, and in the surrounding areas. How we build the interfaces, how we empower our public in this area and other areas, and how we prepare for what we are about to face and drop our mortality rates to match those of the best countries in the world. And if I had a time machine to go back in time, this is kind of where I'd be. I'd be thinking about how to use the patient safety collaboratives to try and bring together deterioration networks to do with COVID, form our stakeholder groups, get commissioners on board, clinicians, develop our strategy, beg, borrow and steal pathways, develop our own where they're not a good fit, get the resources together, and then join the community of practice to help others. So thank you so much for listening. And without further ado, I'd like to hand over to Bushra, who's going to tell us what the wonderful work she's been doing in Manchester.
Oops, fantastic. Thanks, Matt. Katie, are you able to share my screen? Oh, fantastic. Thank you. So thanks for inviting me to talk to you today. I'm Bushra Alam, Acute Medicines Consultant at Salford Royal, and I'm also leading the development of the COVID virtual wards. So in this talk, I'm going to address the following points on the slide: why this is important for us to do within Greater Manchester, what are the challenges we faced at organisational level, how we scaled up from one organisation to involve the entire GM in a system-wide approach, how we managed to engage our stakeholders, develop our mission statement, a little bit about what our localities are doing now and what our present challenges are. Okay, so towards the end of July, I received an invitation from Matt with slides detailing the COVID virtual ward pathways. So they came at a time when Oldham and Rochdale locally were seeing a rising number of cases with COVID and had local lockdown measures in place. Oldham faced significant challenges in trying to deliver its business as usual. We were all concerned about a second wave and the upcoming winter, and we all felt a real need to do something different and to be able to do this winter to allow us to continue offering our services. So the first challenge was to engage our senior leaders as to why this was important and why adoption of these pathways was a key priority for us. Recognising those that are sick is advantageous not only to the patients in terms of better outcomes, but also to secondary care providers. For patients, as Matt has said earlier, early recognition is critical for survival. I mean, we all saw patients that present late and extremist to A&E. One of our nurses presented with saturations of 88% and a new score of 10 on A&E triage. And we all have experience of patients that have come in dehydrated, acute kidney injury, myocardial infarctions, strokes and PEs, to name a few. And this is because they've all been very sick at home with COVID. Last week, one of my patients was one of those late presenters, a 63-year-old, relatively well, day 8 into his COVID illness, and he developed a heart attack. So he came in very breathless with lungs that were full of pulmonary edema and also COVID inflammatory changes. And there was nothing that I could do for him. But I did think if I picked him up earlier and he was a patient on our COVID virtual ward, could his MI have been preventable? And would I this week be discharging him back home to care of his loved ones? So at organisational level, these pathways are really important. They will help to keep our A&E attendances low. They will help us to reduce our length of stay by either discharging patients from A&E or from SDEC pathways. And they will also reduce our inpatient length of stay. We all have significant challenges from nosocomial spread of COVID in hospital. So we have a greater need to make sure that those that can go home can do so safely. We've accepted that earlier intervention will also reduce critical care demand. At Salford, we are a major trauma centre for the area, and we cannot have our 8-bedded resus full of COVID patients. So this has been recognised by our care organisation, and the COVID virtual wards and respiratory pathways are now priority in our winter plan and to help us maintain our business as usual. And any funding that we have will come from our winter plan. We recognise that we can't simply shut shop like we have done previously. So this invitation from Matt was shared with colleagues in other trusts. We reached out to acute medical colleagues, respiratory, A&E, primary care, hot hubs, CCG, medical directors and directors of CCG. We try to engage everybody with this process. We set up a GM collaborative meeting, rather like this one here today. And there was consensus at that meeting that our current knowledge of COVID had improved since the first wave, and that the current pathways that we had in place did not reflect that, none of which used pulse oximetry. The national guidance that we've been provided with the updated pathways for acute COVID care is not yet mandated, and we recognise that, but we also recognise that there is a clear need to do something and to do that fast, acknowledging that the pulse oximetry would provide us with a more objective means to monitor our patients, and that telephone calls to check up if a patient is okay are no longer adequate. So we've realised that there's also significant variation in what we're doing and significant variation within the locality. And there's no consistency in our COVID follow-ups from acute care. For instance, in my hospital, if you were discharged from A&E or medical assessment unit, you would get a telephone phone call. But if the same patient had gone to a ward and at day 2 was discharged from a ward, they would go to the care of their GP. And a recent survey that we've done locally has suggested that GPs are not very clear on who needs following up, and only 30% of our patients are actually followed up by the GP. So the support within our collaborative meeting in GM has helped drive a system-wide approach. And we realise, irrespective of where you are in the system, you do need that acute follow-up, and you need pulse oximetry to help guide that follow-up. So the group has gained considerable support from all organisations which are involved. And our mission statement is that we want to be able to monitor all patients considered high risk within the first 14 days, and for low risk patients to have access to pulse oximetry if they feel unwell. All our localities have developed pathways now, pathways from A&E, SDEC, wards, and have also incorporated respiratory patients that are slow to wean from oxygen in providing domiciliary oxygen. So the community pathways are the most challenging, and Salford Care Organisation is working with the hot hubs in the delivery of the community pathways. We realised that we probably need some commissioning support, and we've taken our pathways to our primary, community and hospital cells for approval. And all the cells have given their support, and we will continue to work with local organisations to operationalise these pathways and ensure that we have consistent and equitable access. So now our current challenges are that we're trying to develop the right digital solution that's appropriate for us to support our COVID virtual wards. And the digital solution is essential to allow us to monitor our patients at scale. And this work of monitoring acute patients in their own home and using pulse oximetry to guide deterioration, escalating their care to hospital at the point of need is truly revolutionary in acute care. So the implementation of these pathways have been considerably challenging, and we have worked with a number of stakeholders to be able to allow this, but it's also hugely rewarding to work alongside some very dedicated and committed people that have gone above and beyond, invested their own personal time to ensure that patient care is at the forefront of what we do and continue to do. Thank you very much.
Thank you, Bushra. We are now going to hand over to Professor Naomi Fulop. I just wondered, there's a couple of questions in the chat box as well. There's one particularly around News 2 not being valid in community and with COVID. Matt, I don't know if you just want to highlight on that shortly, and with regards to the recap work that Trish Greenhalgh is doing as well. So we can bring that up in a minute. And also with regards to the learning disability population. So have acknowledged those, and we'll answer those at the end of Naomi's presentation. Thank you.
Thanks, Katie, and hello everybody, and thank you for letting me have a little bit of time in this really important meeting to share some findings. So earlier in the summer, Matt and a group asked us to carry out a rapid evaluation of these virtual wards, remote home monitoring models that were set up during the first surge. And I should say my name's Naomi Fulop. I'm Professor of Healthcare Organisation and Management at UCL. Next slide, please. I'm presenting on behalf of this team, and our work is funded by the NIHR. So the next slide, please. Can we go to the next slide, please? Thanks. So what we were aiming to do was, first of all, develop a typology of these models, including their key characteristics that were operating during the first wave, look at the experiences of staff, the use of data, the variability in staffing and resource allocation, patient numbers and impact, and most importantly, draw out the lessons for these models that ran during the first wave for the development of similar services for this autumn and winter, and also identify areas for further research. And I'll say a little bit about that at the end. Next slide, please. So our methods were, first of all, we've carried out a rapid systematic review of the use of remote home monitoring during COVID. And I'll say a little bit more about that shortly. Secondly, we conducted field work in 8 pilot sites around the country that had implemented these models. We interviewed staff, collected various documents, and the sites kindly provided us with data on resource use, staffing, patient numbers and outcomes. And we conducted this study during between July and September. Next slide, please. So this is the rapid literature review. I'm not going to go through it in any detail, but if you just go to the pink box at the bottom, so this is, we've looked internationally at papers published on these kinds of models. We've got 16 papers reporting 17 examples, and it's a what we call a living review, because papers are being published all the time on this, so we're trying to pick up the learning. Next slide, please. And so our learning so far that we've brought together is that, first of all, it's important to avoid framing this model as an admission avoidance model rather than an approach to maintain patients safe in the right setting. Using apps for monitoring allowed follow-up of a high number of patients compared to paper-based models, but some studies indicated that models based on telephone calls were more inclusive for obvious reasons. Patient and carer training was identified as a key determining factor of the success of these models. coordination between primary and secondary care facilitated implementation. Primary care led models were considered in some cases to be more adaptable, and a few models have integrated mental health and social care support, which has highlighted a wide range of patient needs. Next slide, please. So in terms of the study of what actually happened here, it's clear to understand what it is was implemented. So the aim of these models was to monitor patients considered high risk who can be safely managed at home, to avoid unnecessary hospital admissions, appropriate care in the appropriate place, and secondly, to escalate cases of deterioration at an earlier stage to avoid ventilation and ICU admission, and as Matt said, have potential further treatment, including earlier treatment with oxygen. On the right-hand side, the main steps involved in the process. So patient presents at ED or within primary care, or if they're already in hospital, is considered suitable for discharge in the step-down model. Triage to remote home monitoring, onboarded or admitted to the virtual ward with pulse oximeter and information. The patient is asked to provide information on observations through phone calls or the app, and the clinical team monitor observations and escalate potential cases of deterioration. The patient is followed up for 14 days or until the symptoms improved. Next slide, please. So these were our 8 sites. They're around the country. They don't necessarily represent everything that was going on at the time. They're partly recruited through word of mouth and through Matt and his colleagues. However, they do present a nice range in terms of the size of population served and the type of populations. 6 of the models were led from secondary care, 2 from primary care, and 1 started from secondary care and has since become a primary care-led model. 5 were paper and phone based only, and 3 used app and paper and phone. Next slide, please. So this is the typology that we've developed, and there are 3 key dimensions it's important to think about. So the first is the patient cohort, so distinguishing between pre-hospital patients and what's called step down, that's discharge, early discharge from hospital, or mixed. Some services provide both types of care. Secondly, is it organisational arrangements, whether these services are primary care led or secondary care led. And thirdly, the remote monitoring system, whether they're phone call and paper based only, app only, or a combination of the 2. Next slide, please. So these were the expected outcomes as identified by the sites. And for time, I'll skip to the next slide, please. So this is how they operated in practice. Models were designed and implemented very rapidly, often in a matter of days and weeks. Staff drew from experiences of previous remote home monitoring or ambulatory care pathways. These staffing models were highly dependent on people who were redeployed from other areas which weren't operating, staff who were shielding students or volunteers, and heaps of goodwill, as Bushra has talked about. Some pilots had early conversations with each other to share learning and materials, and as Matt's talked about, that's expanded hugely now. And some pilot leads looked at existing evidence such that there was. Next slide, please. So this is some information on staffing models, and I'm not going to go through this in any detail, but really it's to note the wide variation in staffing models across sites, given the context I've already talked about. So people develop the staffing models in a kind of ad hoc way for speed, and therefore they're a description of what did happen. They're not necessarily what should happen now if you've got a bit more time to set things up. Next slide, please. And this sets out some more detail, which again I'm not going to go into, but it's the same point really in terms of the variation. But one of the issues the sites were keen to emphasise was that they were, when we were interviewing in the summer, they were looking at trying to kind of decrease the level of seniority on an ongoing basis, and the type of healthcare professional that would undertake the remote monitoring. Next slide, please. I think we have a bit of a bound. It's popped up. Brilliant. So patient experience, really important. So 7 of the 8 pilot sites documented patient experience through surveys or questionnaires. Patient experience was described as positive, high levels of patient engagement, and the reassurance service provided was really appreciated by patients. Some of the problems that were raised, some patients had increased anxiety through being monitored remotely, and there was a reduction in patient engagement during later follow-up calls. Next slide, please. We've drawn out some of the differences between models that were led by primary care or secondary care. There was greater data linkage in secondary care models. There were lower patient referrals in the primary care models earlier on in the pandemic. And there was a greater range of senior staff involved in providing clinical oversight in the secondary care models, although, as I mentioned, many question whether this was necessary going forward. Next slide, please. So we've looked at the data and evidence used by the sites. The first, in terms of collection of setups, so sites were collecting combinations of clinical readings, demographics, patient experiences and outcomes. Because they acted really quickly, there wasn't really time to carefully plan data collection or go through the IG implications. But data collection outside apps could be cumbersome, although even with the apps, that could be the case. The data quality is variable. The data sharing within and between sectors hasn't been well established, and data linkage has been difficult, and relatively little external evidence to advise on setup. Next slide, please. In terms of how data are used, they've started being used in a more sophisticated way, for example, for predictive impact of oximetry readings. There's suggestions of overcoming small numbers by combining data from different sites. There's some proactive use of data to inform improvements. And comparators are difficult to establish, and I'll come back to that at the end. Next slide, please. So in terms of patient numbers and impact, the first thing to say is that these data are based on the data the sites gave us, and we don't have any comparison group. So we have to be careful in terms of thinking what this really tells us about effectiveness. I've highlighted in red, so in terms of the proportion of patients who deteriorated and escalated, that was 10% in the pre-hospital model and just over 12% in the step-down model. The mortality rates were around 1%. And then the table below gives more detailed account of what happened to patients who deteriorated and were escalated. Next slide, please. This slide and the next slide look at the costs. This is of the pre-hospital model. The next slide is of the step-down model, and this is based on the staffing data that were given to us by the sites. So again, they provide limited basis for future planning. They tell us what did happen in terms of cost rather than what should happen. Next slide, please. Thank you. So I'm going to go through very quickly some factors which facilitated implementation, and then some which were barriers, and then some headlines takeaway for you to take away. So in terms of facilitating factors, the role of influential dedicated clinical leaders in establishing these services was really important. There was significant support and buy-in from senior management within acute trusts and across CCGs. I've mentioned previous pathways in place, such as for ambulatory care, which supported the setup of these virtual wards more quickly. Developing paper and video patient information, as well as using digital platforms, was very useful to explain the concept of virtual wards and how to take measurements. And that links to some of the queries about and issues raised by Matt about reaching the whole of the community. Positive engagement from patients and trusts in clinical staff, was reported as important. Next slide, please. The sites told us that the majority of interventions can be delivered by nurses, both in primary and secondary care, with minimal senior clinical oversight. I've mentioned the collective spirit and goodwill, which raises issues about sustainability in the long term, clear staff communication, and acute trust IT teams willing to adapt in terms of their protocols. Next slide, please. Some barriers to implementation as they were set up. Referral criteria and processes weren't always clear, so sometimes unsuitable patients were being referred, and that was in part caused by evolving criteria for patient referrals. In terms of monitoring, it's difficult to do non-verbal assessment using phone and video consultation alone. Some patient groups are difficult to monitor remotely, such as the homeless community, and monitoring using an app-only model is not sufficient for all populations. And there was at the time a lack of availability of culturally appropriate information in different community languages. Next slide, please. In terms of resourcing, there was a lack of administrative and project management support and resources, and particularly in obtaining pulse oximeters quickly. It was challenging to deliver a 7-day service due to workforce availability, and various challenges around data, linking data from apps and spreadsheets to existing primary and secondary care data sets proved difficult, and that's something that needs to be addressed. Linking data with NHS test and trace was problematic, a lack of published evidence to support the design, and it can be difficult and time consuming to collect desired data even when patients are using apps or using wearable technology. Next slide, please. So some headlines, takeaways on one slide for you if you just want it all on one slide. So in relation to patients and staff, patient experience was described as positive. Staff described high levels of patient engagement. Monitoring patients remotely was perceived to reduce the risk to staff from contracting COVID-19. We didn't have a control group, so it's not possible to look at effectiveness. The mortality rate of 1% appears low, especially compared with other COVID-related mortality rates. We need to be careful about that when drawing comparisons. In terms of care, patient carer training is key to success. The app-only model is not appropriate for everyone. We need to have the phone and paper option as well. Personalised support is required to avoid patient anxiety and reach those who may be difficult to monitor remotely, such as homeless people. Information needs to be culturally appropriate and in different languages, so both of those two issues need to be addressed. In terms of resourcing, site leads they are considering whether monitoring can be carried out by lower bands with senior level input. There's a concern over sustainability of services as they were set up on discretionary input, but they require dedicated funding, clinical and administrative project management support. The 7-day service is a challenge, so need to consider links with 111 and out of hours. There's an opportunity to expand these services beyond COVID to other acute respiratory illnesses and potentially long-term conditions. In terms of implementation, these services were established very rapidly. Whether they're primary or secondary care led depends on where these services arose and what existing services were in place. Need to have clear referral criteria and processes to ensure the service is targeted at patients that can benefit most. Timely access to pulse oximeters is essential. Data is a challenge, particularly for primary care led models and across primary and secondary care. And better integration is needed with test and trace to streamline referral processes. And just one last slide, which I won't go through in detail, but which raises issues for further research. And I'm sure it will come up very shortly. I think it's a bandwidth issue. Thank you. And it's really to let you know that our research is going to be continuing this winter, and if you establish these kinds of services and wish to participate in the research, we'd be very happy to work with you. Thank you very much. Very happy to take any questions.
Thanks so much, Naomi, and to Matt and Bushra as well. We have about 10 minutes to answer some questions. I think Andrew has collected a couple of them that were in the chat. I've sort of lost access to the chat temporarily. I think there's one in particular to learning disabilities. I think we need to answer. I don't know, Matt, if you can answer that one for us. I think it looks like we've answered the question with regards to news and COVID in the community, but if anyone feels that we need to explore that a little bit more. And then
Katie, what's the question on LED?
So, Matt, it was, so I've got a list in here. How does this apply to people with a learning disability who might live with family, alone, or in their own supported living tenancy and not a care home? And that's from Lynn James Jenkinson.
It's such a good question. We have not done enough for people with learning disabilities. We've not done enough for people with cognitive dysfunction or mental health, or don't speak English as a first language, or are poor, quite honestly, throughout the COVID first peak. So from a learning disabilities perspective, there's a really damning report that's just about to come out that's looked at COVID deaths and the avoidability of COVID deaths. And, I think we need to really think about how these lessons from first peak and take them to heart in how we address second. And that is about the all-cause deterioration strategy and pathway that involves giving people who are carers, people who are loved ones of patients with learning disabilities or cognitive dysfunction, a voice. And that's with things like the soft signs of deterioration, Restore 2 Mini, and the strategy of training them up in a way that they can escalate their concerns in a way that the NHS will respond to, and about training the NHS to be able to respond properly to what carers say when they're worried. And, this is an ongoing battle for us, and the ball is in our court to do something about it, not just for COVID, but for all causes of deterioration in all settings and for all patient groups, even those who don't have a voice. So, the gloves are off. We've got to do something about it. The ball's in our court, and we will do something about it. So that's the promise back, quite honestly, because enough's enough.
That's great. Thanks, Matt. Okay, Matt, another question for you from Richard Priest, which I think you may have touched on, but these data show people with low O2 sats admitted to hospital have poor outcomes. It doesn't necessarily follow that early detection of low sats or oxygen therapy or earlier admission change those poor outcomes. Am I missing something?
No, you're not. You're right. And what we really need is a prospective validation cohort. And the difficulty we're going to have going forward is obviously whether we have areas of the country who don't implement this to act as a comparative population, and whether that's ethically correct or incorrect. And, it's really difficult, isn't it? Because I think our mortality rate's going to drop for a number of reasons, not just the COVID virtual ward model, which, personally, I think will really help, but because of drugs like dexamethasone, earlier oxygen, proning, avoiding intubation and ventilation, as we know, anticoagulation. So it's going to be difficult to sort the wheat from the chaff. And in some ways, I guess we're not worried. We just want better outcomes, don't we, for our population, for our relatives, for the people we treat. But you're right, from a purely conceptual model, it would be lovely to go back in time and do that double-blind randomized controlled trial right from the start. But, hand on heart, we cannot prove it.
Okay, thanks, Matt. I think a follow-up to that question, and I think you've already answered it actually, was from Dave T around, it was a leap to say that virtual wards will reduce mortality, but he also mentions that Qatar is not a good comparator with the UK because of different demographics.
Yeah, Qatar's just an example of one of the 5 countries that had really, really low mortality rates. And I put that there just because we don't think of Qatar necessarily having the most developed healthcare systems, and I thought it was a good example as a result. But that came from a paper, and I can share the link, from 29 developed countries around the world, and where they set their oxygen level for admission and treatment compared to their mortality rates. And what they found was that when they surveyed England and the United Kingdom, most people responded with 91% being the oxygen level that we should admit and give oxygen treatment for. and the other countries of the world that did better than us essentially had 94, 95%. And it's a beautiful linear relationship, and a very interesting paper to read. There were a ton of other countries that did better than us. You know, we were probably around 26th in the world out of 29 in terms of case fatality rate. And I appreciate our testing mechanism was also different. And I think what we've learned from time-sensitive conditions, you know, in the past, and you know, do we want to go back in time really, is that the earlier we probably get to patients that are deteriorating, probably the better as a healthcare system. The earlier we admit people who probably need admission, the better. And from my anecdotal experience of seeing patients with COVID at various different stages of illness, you know, and this is heavily biased, but, you know, people just seem to have done better if I get to them a few days into their illness with SATs in the low 90s compared to 10 days into their illness and SATs in their low 60s. And I suppose that's the mental model, probably influencing my bias on all sorts of levels, that is potentially driving my desire to get this everywhere.
Thanks, Matt. I think we're just pushing on time a bit now. There are two questions in particular with regards to any current guidance on steroid use, so DEX in the community, and also with regards to any use with a guidance with low molecular weight heparin as well. I think we've probably only got time to just brush over those quickly and then talk about the sort of next steps of this group and this network from a practicalities point of view, and hopefully that will answer your question, Lalit, as well.
So briefly, yes and yes. We've got to do both. There's a national guidance group that's meeting as we speak, and whose meeting I missed because of this, that is addressing low molecular weight heparin, dexamethasone, domiciliary emergency oxygen supply, trying to write a protocol for that, essentially to work for patients that aren't suitable for emergency admission, but who still have a fighting chance. We all know stories of 100-year-olds who survived COVID. You know, why shouldn't you give them treatment in the community? Just because they're not for emergency admission doesn't mean we give up on them. And, you know, this is what that meeting's about.
Great, thank you.
Right. Thanks, Matt. Just to acknowledge, there were a couple of questions around News 2 not being validated in the community, but I noticed, Matt, you've already you've posted in some links to research papers. Yeah, great. Okay, to answer those questions. And one final comment just to pick up, we already have established programme boards in the 3 systems within the Northwest to implement remote monitoring at scale. We need to link into these existing boards because this work is already going on. That comment from Tony.
Thank you, Tony. So regarding next steps, this is a developing network which will form part of our managing deterioration patient safety network as well, and this will be a subgroup of this. We are wanting to do whatever we can to support you rapidly deploy virtual wards. From a practicalities point of view, we appreciate there's a lot of information that's being given here, but what we do have, we're building a toolkit and resource pack at the moment on a how-to guide. We'd love to hear from you if you would like any support in this whatsoever. We have appointed our clinical lead, John Caldwell, as I've mentioned, who's a GP in Merseyside. They're linking up with telehealth in Merseyside as well, so looking at how their remote monitoring can be expanded into their 24-hour existing service. So some really exciting work going on. So I guess with regards to next steps and how we get this going in the Northwest is very much down to you guys and how you feel you can work within the systems and what support we can give you. Very much learning from Bushra and the team in Greater Manchester. But does it help to pull together another meeting in the next week or so for you all, so that we can look at whether things have progressed, whether there's any help, whether we've got the right people in the room? It'd be really interesting to hear back from you about how we manage this next step now. Thanks, Jackie. I don't know, Bushra, if you want to add any comments here into the best way to mobilise from this point and what your experience is from well, getting lots of yeses. That sounds good. Maybe that's our next step then.
Yeah, I think it's just really important to have the weekly collaborative meetings so that you can start mobilising at pace, because I think that's the most important key here, that COVID is not waiting for us. So I think we just really need to move very quickly. So weekly meetings helpful.
Yeah, you've got our help if you want it. Okay, you know, we've got a team that's hopefully forming pretty quickly, and people like Bushra and you know, enthusiasts all around the country. Essentially, the forum, as I say, please join. 550 members growing strong, and the fortnightly webinars, again, massive interest. So anything you need.
We'll share the information from that in a post meeting follow-up email. We'll send all the information that we've put in the chat box as well, and try and answer any further questions. Make sure that you've got our details so that you can be in contact with us. We will arrange a meeting for this time next week as well. Does this time work for people? 5 o'clock? Is it a good day for people? Great. So we'll proceed with that then, and getting things going. Please do contact us in the meantime. You've got my email. We've also got the patient safety team email global address that we've given you, so that you can contact on there, and that's dedicated for this piece of work at the moment as well. And we will be in touch. So I'm an absolute stickler for time management, and the fact that it's 1 minute to, and I think we've wrapped this up. And I think we'll call it a day for this evening. But thank you so much for giving up your time, and for coming to this at such short period and such short notice, and look forward to working with you all and supporting you on this piece of work that we need to rapidly deploy to make our system safer and to respond to what's going on at the moment. So thank you very much, and we'll speak to you soon. Thank you.
Thanks,
everyone.
Bye-bye.
Hi, John.
Hi. You okay, Katie?
Very well, thank you.
John, hi.
Hi, Matt.
You look well. How are you?
I'm very well, thank you. Yes.
Oh, great to see you.
Yeah,